Today, we're going to talk about metatarsalgia. Again, this should be fairly quick today. All right, so this is kind of 5 tips. And obviously, my disclosure is I'm the medical director of ProLab Orthotics. But there's nothing in here that's really specific to ProLab. Whatever lab you're using, you can certainly incorporate this into your orthotic therapy. So obviously, metatarsalgia is kind of a garbage term. So what we're talking about here is simply anything that causes pain under the med heads, whether it be capsulitis, a plantar plate tear, a neuroma, even ulcerations. You can look at these same orthotic modifications as being valuable. Forefoot pain associated with rheumatoid arthritis, painful keratomas, whatever it might be that is causing pain from pressure or pathology from pressure under the metatarsal heads. And with that, that's a little simplified when I say pressure, because really we're looking at accomplishing 2 things here. One is to reduce forefoot pressure on all these pathologies, and on some of the pathologies, primarily callus, blister, and ulcer, we also want to reduce forefoot friction. So we'll talk about that at the end. So let's look at reducing pressure first. First of all, I think a key point of this is to use non-deforming materials. And this is true whether the patient is an athlete with no underlying medical problems, or whether they're a diabetic patient who has neuropathy. We have a tendency with those patients to use softer devices, but the literature really holds up that more rigid orthoses will do a better job at transferring pressure. There was a study, just one study, Chalmers back in 2000 noted that semi-rigid orthoses had a significant effect on pain. These are on rheumatoid arthritis patients, where soft orthoses or shoes alone did not. And it makes sense. If the device is too soft, it's going to deform under the foot and it's not going to transfer pressure. More rigid devices will transfer pressure. So those could be polypropylene, they could be carbon fiber. There's all kinds of ways to make a more rigid device. You could take EVA can be rigid if it's thick enough. So I'm a fan of polypropylene over most materials, because if it is too rigid or it feels too high, I can easily grind it thinner from the bottom of the device, make it more flexible at any point that it's bothering the patient. And it's just a really quick, easy adjustment to make. Second, close conformation to the arch of the foot. Hang on, it's falling up on my fire. I will be right back. I gotta return a quick text. All right, sorry about that. So the study by Mueller has done a lot of work on orthoses for patients with diabetes. And this 2006 study, they looked at the efficacy and mechanism of orthotic devices to unload the med heads in people with diabetes and a history of plantar ulcers. But again, we're talking about unloading the med heads. So whether it's a diabetic ulcer or whether it's capsulitis, the concept should be the same. And what they found is that a total contact insert reduces excessive pressures at the med heads by increasing the contact area forces. What he's saying there is something that conforms close to the arch. Here, I put that patient in a casting position on both feet. This device that conforms close is going to have a greater contact area posterior to the med heads and do a better job of redistributing that force than this one that gaps from the arch. How do you get that close contour to the arch? Is number 1, good cast technique, neutral position, and plantar flexing the first ray when you take that image or that cast. And this doesn't matter whether it's plaster or scanning, it's just a matter where you're holding the foot. And then prescribing a minimum fill, meaning that you're telling the lab, as in this picture farthest away, not to add much fill into the arch. Most labs will allow you a minimum standard or maximum fill. A maximum fill is a lot more plaster in the arch, and when an orthosis is made off of that, it's going to gap away from the arch. A minimum fill should be fairly close. But keep in mind, this is going to vary between labs. My lab, the one I work for, we tend to go really close contour, very minimum fill is truly a minimum fill. Other labs put more in there. It's not, I'm not saying that's good nor bad. It's just that you have to be aware. You may, a minimum fill with some labs may not really contour to the arch of the foot. You may need to do something else to get that contour. You may either need to tell them, I just want that a super minimum fill or a very minimum fill, or you could invert the positive a few degrees. By inverting that positive, you will also raise the arch. You can see this one is thicker under the first than under the fifth, and that's going to drop down farther to the ground than from the apex of the arch, and you have a higher arch. So if I want a really, really close contour, I'll often do a minimum fill and a couple degrees of inversion. That's kind of my standard. But again, that's with the lab I work with. The lab you work with may be a very different shape. So you need to work with your lab, get comfortable with what their standards are, and talk to them. Find out how much. There's usually a standard that people are adding for each of these, and they can tell you what that is. You can use metatarsal pads and bars to transfer pressure. Hastings, who actually worked with Mueller in 2003, noted that met pads placed between 6.1, it's pretty exact, and 10.6 millimeters proximal to the met head resulted in a significant peak plantar pressure reduction compared to wearing the total contact insert only. This was an interesting study. This was an interesting study. What they did is to do a combination of in-shoe pressure studies and a spiral CT to see exactly where that met head, where that metatarsal, pardon me, where that metatarsal pad was placed. Now, this is a metatarsal pad, obviously, at the bottom. We call this a metatarsal bar. It's just a piece of poron placed all the way across, full thickness distally and beveled more proximally. Yeah, that one, the Met pad has by far the best studies. I think it probably does the better job of getting pressure off a single metatarsal head. But if you have more of a generalized metatarsalgia, that Met bar will do a good job of transferring pressure off the Met heads onto the metatarsal neck and shaft. And it's a little more forgiving. I mean, no matter how good a metatarsal pad is at transferring pressure, some people just don't tolerate them, where most people tolerate that Met bar fairly well. And you can add to it. Sometimes I'll add layers on top of this right behind the Met head that has the most pain. So you can play around with that. Again, it's a matter of transferring pressure. Karl Landorf did a study in 2014 where he was trying to determine the optimum pad placement for metatarsal pads and bars. So he did this. He had a control with none. He had a Met pad that was placed 10 millimeters proximal to the Met head. He had one where the distal end of the pad was placed 5 millimeters distal to the Met head. He had the Met bar, and then he had what they called in this study, or I guess what they call in Australia, is a plantar cover. That's a combination of the Met bar plus a poron extension under the Met heads. And they found that the Met pad that was 10 millimeters proximal decreased pressure, peak pressure by 9%. The Met bar alone, 10%. The metatarsal pad 5 millimeters distal was 17%. And that combination of the Met bar and Met pad was 19%. So the cushioning made a difference. We'll talk about that in a second. I wish he had done one more. I would have loved to have seen this Met pad with the 5 millimeters distal plus the plantar, the cushioning under the Met head. I think, makes sense to me, that would probably be the most effective. With that, I would always recommend, anytime you're prescribing a Met pad or a Met bar, or you think you might want one later, ask your lab to only glue the proximal end of the cover. We call it glue posterior only. And this will leave that pad exposed so you can adjust it, you can add to it, you can shave it down, you can move it. I mean, obviously, we can look at these studies and say, okay, well, this is exactly where we should put this for best outcome, but it doesn't mean the patient's going to like it there. So I will often give them, I almost never dispense orthoses with pads or bars on there, partially simply because if the device isn't comfortable, I don't know what's doing it. I don't know if the problem with the shell, or I don't know if it's just they don't tolerate the Met pad. So I'd rather leave this unglued and then add that subsequently after they do a break-in in the office. And then I sometimes just give it to them and let them place it at various spots, just taping it in place, find out where they like it, outline it with a Sharpie in the most comfortable position. I'll give them a guide to essentially where I want them to start, and then have them outline it in the most comfortable position and then go from there. Forefoot cushioning is obviously critical. I think we demonstrated that in Landorf's study. Certainly seems to be. Probably what it does is it decreases force by decreasing velocity. So that might be a really good orthosis. We've got obviously we can't tell how well this contours, but we'll assume this contours well to the arch of the foot. We have a met bar there. We have a pour-on extension. We left that cover unglued. Should be a very good start on getting an orthosis that will transfer pressure off of the off the met heads. And obviously, any of these modifications don't have to be done on a custom orthotic. You can do these on a prefab and get a less expensive option for people. I always look at orthoses as I think there's three main levels. You have a prefabricated orthosis, a custom orthosis, and in between those, you have the modified prefab. And I think we can do a lot with the modified prefab. You find a few that you like, keep them in the office, and have those available. But get prefabs that are fairly easy to adjust, and then charge for that. I think that's only fair. All right. So then we also talked about reducing friction. We talked about this a little bit last week, I think, I can't remember what we were talking about, but I know this came up. But you can use a PTFE patch to decrease friction to decrease potential for ulcers, calluses, and blisters. Everybody make sure that they are muted, please. And so these are interesting little things. If you weren't here last week, so this material, pardon me, has the lowest coefficient of friction of any material available to put onto an orthosis. You can obviously want to combine that with an offloading orthotic that will help neutralize the, one second here. There we go. With an offloading orthosis, and then you can neutralize the primary causes of these ulcers and calluses. That you've got both the vertical pressure forces and the horizontal forces, which are shear forces. And then you can put these in any area on the orthosis that there might be a callus or ulcer. They're self-adhesive, they're sweat and water resistant, meaning they get wet and the coefficient of friction doesn't change, latex free, and then you can just peel and stick them on the orthosis wherever you might need it. Here for a callus, for example. So here's the summary. You're going to get best outcomes for metatarsal pain if you can prescribe orthoses that decrease forefoot pressure. My top 5 tips there: use non-deforming materials, prescribe it and cast it in a way that it conforms close to the arch of the foot. Use met pads or bars to get more pressure off of it, or at least leave it with the cover unglued so you have that option to do so. And use forefoot cushioning in addition. And then decrease forefoot friction by using these PTFE patches. You can get these, there's actually get these on the ProLab site. There is a website for PTFE, and I don't know what offhand. I think it's ptfepatch.com. That's polytetrafluoroethylene. And this was actually interesting material. This was developed, PTFE was actually developed initially as a suture for very fragile tissue, such as nerves, because it has such a low coefficient of friction. And it's also used as for grafts, cardiac grafts, because it has such a low coefficient of friction. But it's approved as a level 1, or I think they call it class 1 orthopedic device by the FDA for this reason. All right, that is all I have. And anybody have any questions? If you do, please put those into the chat. Okay, for those that have showed up a little bit later, we are going to be doing a webinar next week. It'll be Dr. Diane Mitchell is going to be talking on Wednesday at 4 p.m. Pacific, 7 p.m. Eastern on orthoses and other conservative treatment for the cavus foot. It's an excellent lecture if you haven't seen it before. And if you guys have any, let me give you this next slide here. Here's our content. Well, first of all, let me go back to that. So there's a lot of good information on the website. You can look by pathology. We have a number of these lectures actually that are there and recorded on various pathologies. So those are always available. We have this book available, Paul Scheer wrote in 2011. If you're a client, we have medical consultants, either Diane or I are available. But if you have any topics you'd like us to cover here, shoot us off an email to cs@prolab-usa.com, customer service, cs@prolab-usa.com.